Hi, Dr. Langston. Hi, Dr. Daniels. Could you guys just like in 30 seconds or less introduce yourselves? Perhaps Dr. Daniels, you go first.
Well, thank you, Darryl, for having us. It's great to be here. Dr. Daniels, I'm associate professor at Arizona State University, and I mainly focus on sort of health services intervention research in the cancer space.
And what does intervention research mean?
Developing sort of intervention with regard to how to support, in this case, couples to navigate healthcare systems together.
Great. And Dr. Langston?
Hi, I am Marvin Langston. I am an assistant professor in the Department of Epidemiology and Population Health at Stanford University. And I mainly, I'm a cancer epidemiologist by training. And so I mainly look at risk factors and outcomes for prostate cancer.
Cool. And like in 9.5 seconds or less, what is an epidemiologist?
Yeah, so we epidemiologists wear many hats, but some folks look at us as more like disease detectives, trying to uncover, what are risks of disease in populations and how diseases may spread in populations and which populations may be more susceptible to certain diseases.
Great. What interests both of you about sexual and gender minority population with vis-a-vis prostate cancer?
Yeah, so I can take this one. So really, it's really interesting, the landscape of sexual and gender minorities in this country growing as a population, and even with some of the younger populations reaching upwards of 20% of the total U.S. population for some of the younger cohorts. And so this is a growing population that is largely missing in the prostate cancer epidemiology world, and in some respects is missing in terms of the prostate cancer care experiences. And we can talk about some of the reasons why they're missing probably a little bit as we're going through this. But part of it is the issue around disclosure. Folks don't necessarily disclose their sexual orientation or gender identity with their providers for various reasons. But also, there isn't a nationwide effort to capture this information either in cancer registries or in a lot of health settings. And so there's really few opportunities with which this information gets translated within the healthcare system.
Dr. Danis, why do you think people aren't, and investigators and just survey researchers and what have you, are not asking whether somebody's gay, straight, or whether it's you're a man with prostate cancer who enjoys sexual activity with other men?
Well, I think there's a few places where there's known limitations in this space. So for our health systems data, for any clinic that you go to register and to identify yourself, that question about sexual identity, gender identity is often not asked and included in the demographics when you sort of describe yourself. And so as a result, when you think about identifying folks that might need an intervention or support around sexual identity, gender identity within sort of cancer space, prostate cancer support, it's hard to find folks if they have not already identified themselves as gay, bisexual, or trans women. So that's one area.
Yeah, and one of the things of doing these virtual kind of presentations is I have to imagine, well, I don't have to, I mean, I literally have 10,000 people sitting behind me throwing popcorn and potatoes on my shoulders saying, ask them about this. And, wouldn't a simpler, a more common experience to our patient population be that most doctors are heterosexual, and many of those heterosexual doctors are bigoted or homophobic or are struggling with connecting with a gay man just because of how they grew up?
Yes, you're right. I think that most doctors, it's known that are heterosexual. I think though, instead of it, some are likely homophobic as well, but there's also a big population that are saying, well, why do we care? Why do I need to know? And so that's a huge population. And I think through our research and research of others, we're starting to kind of uncover why you need to know for prostate cancer. But I think a third part of this is oftentimes clinicians feel that by asking the question, they will be disrespectful of the patient, or the patient may not want to answer, or they may give not truthful information. And so why ask in the first place? Now, there's been studies, a really interesting study that showed that this is actually not the case. So there was a study that they asked about disclosure from the patient perspective and from the provider perspective. And about 10% of patients felt that they would be off-put by the question. And about another 10% of patients also said that, well, we wouldn't respond, correctly to this question. And then providers, around 70% said that their patients would be off-put by the question, and about 70% said that their patients, would not respond correctly to the question. And so you can see that mismatch, right? And so I think that some of this really is important to educate providers in understanding that, a lot of the population, when reached with this question, they will treat it like any other demographic information, like age or height, and weight and that sort of thing. And so the question should be posed.
Yeah, and those kind of questions, and there are several surveys that sort of illustrate, whether it's 70%, there was one that was close to 89% of providers wouldn't ask because they thought they would insult their patient or something around that way. It presumes that doctors care about what their patients, how they're going to react or whatever, because you would never have a doctor say, do you have grandchildren, with a concern, or like, how long have you guys been married if a heterosexual presenting couple were in their office, or however you want to play it. It's only around this issue. You wouldn't have questions about race either being a stumbling block, and the argument will be, well, I could see what they look like, but I mean, that's nonsense. I mean, it's about, how the doctor and the patient relate to each other. With that in mind, why do you think it might be helpful or harmful to a patient to disclose who they are right up front, whether there's a form to fill out or not?
Yeah, Joseph, you want to take this one, or?
Well, I mean, I think there's a couple different answers here. I think for sure, patients need to assess their communication and relationship with their provider for sure in order to make that decision. I think linked to this is, if I may go back a little bit, we talk a little bit in the paper about there's sexual gender minority or LGBTQ health competency training that's often provided to general practitioners, but this is not filtered up often to sort of specialist training. So that's another sort of way or places where we need to focus our attention, I think. But with regard to disclosure and making choices about when to disclose or not, for me, I think it really depends on the relationship with their provider. I think there are inherent risks, and then, risks based on potential perceived stigma or discrimination that someone might experience from disclosing.
I think just to follow up too briefly here, that is a risk, but some of the benefits though are kind of just this like increased trust in the patient-provider relationship, right? The feeling of this person gets me, this person understands my experience. There's opportunity also for less kind of decisional regret. So often folks feel that, if you have enough information, education about all of your treatment options, and included within that is, your general demographics and your risk factors, then, there's less opportunity for decisional regret. Another piece too is by disclosing, you kind of help to bring your partner into the cancer care experience. And our paper kind of touches on this a bit as well, and the importance of bringing that partner in. And we've done some research too, where us and others really, it's well known that for heterosexual couples, there's this huge benefit of coupling or marriage in terms of prostate cancer survivorship and quality of life. Part of that is, through navigation, so helping you to, understand and navigate the healthcare system. But we really don't quite understand how that it plays for couples that aren't heterosexual. And another issue too, we had a paper where we were looking at follow-up care post radical prostatectomy and or surgery for localized prostate cancer. And we found that one of the strongest predictors of who was following up and receiving follow-up care was marriage, like those folks that were in marriages. And so we really, Joseph and I, one of the really important lines of our research is really to kind of understand, does that survival benefit, do those benefits of heterosexual marriage in prostate cancer care, do they also translate for, gay and bisexual men?
For our audience, we'll have links to those papers below, and you're also welcome to email Male Care. We'll have those in our research section on the website. And when Dr. Langston said Joseph, that refers to Dr. Daniels, who's Joseph Daniel. And Dr. Daniels, you could refer back to Dr. Langston as Marvin if you want, or however. So I mean, but we'll keep our titles solid. But returning to the idea of disclosure, in a way, it's, I mean, from our population, our support group attendees, we've learned that it's a bit of a test as well. I mean, there's less an expectation that any doctor, gay or straight, will understand, my experience as a patient until I spend hours with them over multiple days and weeks and months, and just warming up and getting to know each other. But the idea that somebody might be able to clue themselves to a patient simply by the split-second reaction of hearing the word gay or bisexual or I love other men, or can I talk to you, a man presenting with his wife who's deep in, who's on the down low, and he says, can I speak with you privately? And the doctor doesn't get a clue that he's going to tell something that he doesn't want his wife to hear, and that's an opportunity to understand the patient in a deeper and more responsive and shared decision-making sort of way. The opportunity to sort of disclose is full of risks that are imagined. Do either of you have any thoughts about that? That patient imagines, but may not actually be, in fact, an experience.
I think inherently as LGBT folks, we have sort of medical mistrust built in. And so we do need to acknowledge that. And that can influence how we make decisions about disclosing to our provider. And like Marvin said, providers, may be competent and open to the conversation, but may be hesitant to have the conversation or initiate it. So but I don't think that we're seeing a lot of evidence toward, blatant discrimination as of yet in my research recently. Yeah, I'll leave it at that for now.
I also think that it's interesting because it's really difficult when you have obviously these options of or the experiences of medical mistrust, and what you've been describing, Darryl, is very much what patients go through and how they perceive discrimination, or perceived or actual discrimination within the healthcare setting. But I think in terms of prostate cancer care, oftentimes in our research and the research of others, folks the patients have described this kind of having to be your own kind of best advocate in a way. And I think that men who are thinking about, well, should I disclose, and will I have to face some sort of discrimination from my doctor? I think you should also balance those thoughts with how can you be your best advocate, and if providing this information is another piece with which you're advocating for yourself and your and treatment. And can you talk about some of the treatment-related side effects, such as some of the sexual side effects and some of the urinary functioning side effects, and in a very open and honest way, and maybe by again having all of that information leads to, and giving all of that information, disclosing it, leads to less sort of decisional regret.
Totally.
I think
Look,
I might
go on.
also, in our study, I was thinking a little bit about, disclosing to test with the provider. In our study, we had several participants that described going to different urologists, different specialists, and switching. And I'm beginning to wonder whether, they've done some testing and that provider, they're looking for the right provider for them, which is important for all of us. So I think we need more understanding about how people decide to disclose and how that influences change in care, and that's provided.
Yeah, sure. Your research also brought up a point that I hadn't seen discussed in previous work around coupling and how couples decide whether or not to show up to their doctors together, or only the person diagnosed shows up and the other stays at home or in a coffee shop around the corner. Can you, how did that sort of insight develop, and what do you guys make of it?
I think it developed out of a few different places. There's a study that was run out of New York that described how couples will make a decision whether to attend care together or not, in order to ensure that the partner gets the best care possible. So if they feel like the partner's not going to get the best care, they will not be there with their partner during the clinic visits. We also saw this a little bit we got some information from one of our co-investigators, on the co-authors on the study, about how couples make a decision about to attend or not, based on being comfortable together with their doctor, particularly with prostate cancer. So through our study, we found that couples some of the couples would attend together and some would not. And those that would not would be less aware and understand prostate cancer itself. And there'd be a lot of work that the partner would have to do to educate and bring that person their partner up to the pace to provide that support.
Yeah. Right. And yeah. Go on, Dr. Langston.
That education piece becomes really important, right? And again, we've talked about how heterosexual couples tend to deal with the prostate cancer care experience with oftentimes, the wife has oftentimes even more information than the patient does, right? And kind of keeps the patient on their various treatment regimens and schedules. Whereas what we're seeing is that, some couples don't feel comfortable presenting in the clinical setting together. And so therefore that opportunity for increased education is kind of lost. And you can imagine, a lot of patients, when you're going into seeing a urologist or, seeing a radiation oncologist, there's a lot of anxiety there. And there's so much information and opportunity for information to be lost when, you're hearing about your scans, or you're hearing about, your treatment options. And it's always great to have, someone else there to kind of help with that process. And we're just seeing, we see in some of our research and the research of others how, gay and bisexual men, often they feel, like they're kind of taking this on, by themselves, and they really are trying to seek and find community in order to build community around their treatment and treatment options and that sort of thing, but also in order to educate themselves and to educate their partners.
Sure. And is there a sense that the partner who chooses, or however the choice is made, the partner that doesn't attend the consultations with the doctor, that part of that is to sort of protect the diagnosed guy is trying to protect the undiagnosed guy, or the guy who's not being treated at that particular, their partner who's not being treated, protect them both from, the knowledge of cancer, as well as to protect themselves from hearing, the idea that their partner may think that they're dying, when prostate cancer typically has a long span.
I think in our study, we saw that there is sort of a disconnect in the relationship when the partner is less present during the clinical visits, and it impacts their communication. And we didn't do a measure of quality of life, but other studies have shown that, when you have a disconnected relationship or disengagement with the partner in clinical visits, you start seeing quality of life differences, poor quality of life for the partner, both partners. And so I think we need to do more research to understand quality of life of a couple over time through the cancer diagnosis, treatment, and recovery phase.
Yeah, and good that you mentioned less present. We talk about in psychosocial world where I'm part of, we talk about feeling present,
Mhm.
with their, hearing what the doctor is, being connected in some sort of metaphysical sort of way, perhaps the best to describe it that way. But the idea that someone is physically not present doesn't necessarily imply that they're not present with their partner around cancer diagnosis, treatment, and life.
Right.
And I want our audience to understand that, and that, even though somebody may not physically be in the consult room, it doesn't mean they're not with you 100%.
Mhm.
Absolutely, absolutely. I think what we're trying to say is like, if you get exposed to, in the clinic room with that information real time together, it just makes the communication so much easier when you're dealing with uncertainty at home, like uncertainty about the treatment or the side effects, et cetera. That's all we're essentially saying. But definitely, partners are fully engaged, even if they're not attending clinic visits, et cetera.
Yeah, but also within our study, we did find that so folks that did not have their partner present, there was this anxiety that was communicated where the partner felt that they had to take on the education piece for their partner who may not, have been necessarily caught up with what's going on in the clinic setting. And so I think that is definitely a part of some of this, and trying to figure out ways in which to educate the partner. But some also have pointed out, and this was I found very interesting, sort of some of the reasons why one of the men in our study mentioned that he did not necessarily tell his partner or give his partner a lot of details surrounding the care experience, led to the fact that the partner had a lot of comorbidities themselves. They were dealing with a lot of comorbidities. They were a bit older, and they were the primary provider, care provider for that partner. And so this feeling of not wanting to overwhelm or burden the other partner was definitely something that was there as well that we saw.
Sure.
And then on top of that, to build on that too, we found that participants wanted the just personal time alone to sort of navigate, think through treatment choices, et cetera. So I think it's important to sort of acknowledge that couples can be alone for a little bit to sort of think about, the options ahead of them and the care they're receiving, and that's okay too.
Yeah. And one of the gimmicks that people have suggested is, well, if you don't want somebody there, but you want them to know what went on, you just voice record that thing. I mean, that's entirely accepted now by almost every physician. And, the opportunities of telehealth have emerged mostly because of COVID, but I think technology has sort of advanced dramatically. How do you guys imagine telehealth in all its various forms playing into helping gay and bisexual men get a better experience with their physicians?
Yeah, I actually think that telehealth is this frontier that provides so many different options. One of them is this idea that you can sort of have some sense of discretion as you're going through that telehealth experience. So, for example, the physician or provider may see you as a single individual partner, but if you have your partner there around, in the room, they're hearing the same kinds of information that you're hearing. You can, place the call on mute, and they can ask questions, and you can come in and frame those questions. So I think it really provides that sense for those folks that do like to keep a certain sense of discretion. It allows for that.
Dr. Daniels, do you have any thoughts?
Yeah, I mean, I think in COVID, in our participants, a lot of them talked about some of their support groups being conducted over Zoom or similar modality. And that was highly beneficial to folks, and they greatly appreciated it. But they also would prefer more in-person sort of support groups, and that's sort of for prostate cancer support. But yeah, like Marvin said, the ability to do telehealth generates a sense of control and allows that space to sort of ask the questions that maybe your partner could provide if they can't be there in person, sort of to that support around asking the questions. If you don't remember the question you want to ask, but your partner might remember it, they can be there to sort of slide that paper across.
Yeah, and it's also like a comfort as well, right? So during COVID, we all got very comfortable using these types of technology. I think prior to COVID, you would have a good, percentage of men who would say, well, maybe I'm not getting the best care, or, maybe, I don't know how to use this kind of technology, especially given the fact that, the age range of folks that are living with prostate cancer, may not be, folks may not necessarily want to do newer technology. But post-COVID, I think that it has just been this explosion in telehealth, and it's growing and growing, the amount of folks that trust in it and recognize that a lot of the same kinds of care they can receive via that platform.
Excellent. And there are many gay couples that are biracial. One partner is a man of color and the other may not be or isn't. How does that additional layer play into the discussion we're having?
Yeah, I can answer that question with this in this way. We don't know. I think we largely do not know. There's been very few studies looking at the prostate cancer care experience among gay and bisexual men, and largely they've been among white men, to be honest, and white cisgender men. So we have not done a good job of looking at any kind of racial and ethnic disparities. We have not been able at this point really to do a good job of looking at trans women with prostates either. And trans women with prostates are at risk for prostate cancer. And so those are two communities that we just the research just isn't there yet. And I think that's a major goal for both Dr. Daniels and myself as we move forward in this work.
Yeah, I would add then, other areas have looked at sort of intersectionality of race, gender, sexuality, and there are multiple compounding stigma and discrimination experiences people think about and navigate when they go into the clinical care system. And so at least we have that to build upon for our next phase of work.
Sure. And then there's age differences. I mean, the bears and cubs presenting together and the doctor asking, is that your son? I mean, it's, or is that your dad or however, I mean, there are all these sort of moments of cringe that can play into a patient's consultation with the doctor. And even though those exist in a heterosexual world, there are more opportunities for it, in any minority population presentation. Any final thoughts from both of you? And please have some final thoughts.
I would say, I'm sorry, Marvin, do you want to go?
Go ahead.
I would just want a few things I would say, suggest is that, in our study, we want to thank our participants in our study. It's very important that we really valued their contribution to the study. And I would encourage other GB folks and LGBT folks to, participate in research, because there's so little that we know, and we need to know more about the sort of couple experiences through diagnosis, treatment, and recovery. And there's not a lot of us, but there are more Marvins and Josephs out there doing this research. So I would encourage everybody to volunteer for research opportunities.
Yeah, and I would definitely second that. And I would also say again, as I said, to kind of start this, we really can't study, populations that we don't observe. And so we really need, to have, data from cancer registries, for example, on sexual orientation, gender identity. We need to have standards for collecting this information in the healthcare setting in order to do research to improve clinical care. And so that would be kind of my plug, is to definitely, lobby and definitely, talk with your providers and your healthcare systems about ways in which they are trying to use this information. I can think here at Stanford, for example, we have a campaign going on right now. It's called We Ask Because We Care. and they're asking about sexual orientation and gender identity because they want to improve clinical care.
Yeah, and it's not just incumbent upon patients, people who are patients. The 70 to 80% of doctors who don't ask, to this moment. One of my colleagues put out a Twitter poll 4 or 5 or 6 months ago, asking people, would you ask your patient, asking physicians, would you, radiation oncologists, would you ask? And a bunch of the replies were not only no, but it's irrelevant, and it's not. And even if it actually is irrelevant for a particular case, ask anyway. It's a nice thing to do. It's part of learning who your patient is, and you have the honor of participating in their care. Continue that honor by learning who they are beyond their name. So I don't want patients to feel like the job is yours. Certainly, raise your hand and our male care audience participates. I mean, we have to acknowledge that. I mean, we accrue faster and broader and deeper and larger than probably any game in town or on the planet, from what I'm told. And that's extraordinary honor to be part of that community and to have developed that community that basically has pushed science beyond where it could anyone had hoped for even 15, 20 years ago. So we're grateful for that. And Male Care is grateful for both of you to be part of our conference, to be part of Pride and Prostate Cancer 2023. Thank you for that. And thank you for the extraordinarily important work that you're doing and helpful work that you're doing, and for honoring all of our patient community by just asking questions. That's very cool from both of you. So thank you very much.
Thank you.
Thank you, Darryl. Happy Pride.